Welcome back to the channel. Today, we're diving deep into one of the most important pillars of pharmacology, pharmacokinetics. If pharmacology is the science of drugs, then pharmacokinetics is the story of how drugs move inside the human body from the moment you take a tablet to the moment it leaves your system. In this video, we will 1. Define pharmacokinetics and distinguish it from pharmacodynamics. 2. Explore the ADME processes, absorption, distribution, metabolism, and excretion. 3. Explain key pharmacokinetic parameters such as bioavailability, half-life, clearance, and volume of distribution. And 4. Highlight clinical applications of pharmacokinetics in drug dosing, therapeutic drug monitoring, and personalized medicine. There is a short quiz at the end, so make sure to follow attentively. Pharmacokinetics is often described as what the body does to the drug. In contrast, pharmacodynamics is what the drug does to the body. Pharmacokinetics is all about drug movement, how it enters, moves around, is broken down, and leaves. It is a four-step journey involving absorption, distribution, metabolism, and excretion, collectively called ADME. Let's begin with absorption. Absorption is the process by which a drug enters the bloodstream from its site of administration. To know more about drug administration, follow the link in the description to see our video on the various routes of administration. Absorption is influenced by the following. 1. Route of administration. Either oral, intravenous, intramuscular, subcutaneous, inhalation, topical, etc. 2. Drug formulation. Such as tablets, capsules, liquids, controlled release systems, etc. 3. Physiological factors. These include stomach pH, intestinal motility, presence of food, blood flow, etc. But what really determines absorption is how a drug crosses biological membranes. There are several mechanisms. 1. Passive diffusion. This is the most common pathway. Here, lipid-soluble and non-ionized drugs move across membranes from high concentration to low concentration, without requiring energy. 2. Facilitated diffusion. Here, carrier proteins help transport drugs down their concentration gradient. It does not require energy but depends on specific transporters. 3. Active transport. This requires energy, ATP, and carrier proteins to move drugs against their concentration gradient. For instance, levodopa uses active transport to cross the gut lining. For endocytosis, exocytosis, used for large molecules like proteins and antibodies. The cell membrane engulfs the drug particle and brings it to its site of action. A key concept tied to absorption is bioavailability. This is the fraction of an administered dose that reaches systemic circulation unchanged. Note: intravenous drugs have 100% bioavailability. This is because the entire dose of the drug is introduced directly into the bloodstream, while oral drugs may have much less due to degradation in the gut or the first-pass metabolism in the liver. Once a drug is absorbed, it enters the bloodstream and is carried throughout the body. This step is called distribution. Distribution determines where in the body the drug goes and how much of it reaches the target tissues. Several factors influence distribution. These are: 1. Blood flow to tissues. Highly perfused organs like the liver, kidneys, and brain receive drugs more quickly than less perfused tissue such as skin, fat, or bone. 2. Plasma protein binding. Many drugs bind to proteins like albumin. When bound, the drug is inactive, as only the free drug can cross membranes and produce effects. This binding can also lead to drug-drug interactions when two drugs compete for the same protein. 3. Lipid solubility and ionization. Lipid-soluble, non-ionized drugs cross cell membranes more easily and may accumulate in fatty tissues. Hydrophilic drugs, on the other hand, remain largely in plasma and interstitial fluids. 4. Special barriers. These includes blood-brain barrier, BBB. Protects the central nervous system. Only small, lipid-soluble, or actively transported drugs can cross it. This is why many antibiotics cannot treat brain infections. Placental barrier protects the fetus, but is less selective than the BBB. Many drugs can cross the placenta and affect fetal development. 5. Tissue reservoirs. Some drugs accumulate in certain tissues. Fat acts as a reservoir for lipid-soluble drugs, e.g., anesthetics. Bone can store drugs like tetracyclines and heavy metals. A key pharmacokinetic parameter here is the volume of distribution, VD. This is a theoretical value that indicates how widely a drug disperses in the body. A low volume of distribution suggests the drug remains mostly in the bloodstream. A high volume of distribution suggests extensive penetration into tissues. Clinically, understanding distribution is essential. It affects drug dosing, potential toxicity, and how drugs interact in the body. After absorption and distribution, drugs undergo metabolism. The process of chemical modification in the body, mainly to make them easier to excrete. The liver is the central site of metabolism, although other organs like the kidneys, lungs, and intestines also play a role. Drug metabolism is usually divided into two phases. Phase 1 reactions. These involve oxidation, reduction, or hydrolysis. The main goal is to introduce or expose a functional group on the drug molecule. The most important enzymes here are the cytochrome P450 enzymes. Phase 1 can sometimes inactivate drugs, but in some cases, it actually activates a prodrug. For example, codeine is metabolized into morphine, its active form, during Phase 1 reactions. Phase 2 reactions. These are conjugation reactions, where the drug is combined with molecules like glucuronic acid, sulfate, or glycine. This increases water solubility, making the drug easier to eliminate in urine or bile. For instance, paracetamol is metabolized by conjugation with glucuronic acid and sulfate. Terms to note. First pass effect. When drugs are taken orally, they pass through the liver, which metabolizes some of the administered dose before reaching systemic circulation. This can significantly reduce bioavailability. Example, nitroglycerine undergoes such extensive first-pass metabolism that it's given sublingually to bypass the liver. Enzyme induction and inhibition. Some drugs induce liver enzymes, speeding up metabolism and reducing the effect of other drugs. For example, rifampicin induces CYP450 enzymes. Others inhibit metabolism, increasing drug concentrations and risk of toxicity. For example, erythromycin inhibits CYP3A4, affecting drugs like warfarin. Genetic polymorphisms. Not all patients metabolize drugs the same way. Genetic differences in metabolic enzymes cause slow, fast, or ultra-rapid metabolizers. For example, variations in CYP2D6 affect how individuals process antidepressants, beta blockers, and opioids. Clinically, understanding metabolism helps predict drug interactions, adverse effects, and patient variability. It also guides personalized medicine, ensuring each patient gets the right dose at the right time. After a drug is metabolized, the body must get rid of it. This step is called excretion. This is the process of eliminating drugs and their metabolites from the body. The kidneys are the primary organs of drug excretion, but other routes such as bile, feces, lungs, sweat, saliva, and breast milk also contribute. Renal excretion. Renal handling of drugs involves three main processes. 1. Glomerular filtration. Here, free, unbound drugs are filtered from the blood into the renal tubules. Hence, large protein-bound drugs are not filtered. 2. Tubular secretion. The active transport mechanisms in the proximal tubule pumps drugs into urine, even against concentration gradients. For example, penicillin is secreted this way. 3. Tubular reabsorption. Involves the reabsorption of lipid-soluble and non-ionized drugs back into the blood from the renal tubules. Note: the pH of urine affects renal excretion of drugs. Acidic urine favors excretion of basic drugs, while alkaline urine enhances excretion of acidic drugs. Clinically, this principle is used in drug overdoses. For example, alkalinizing urine helps eliminate aspirin more quickly. Biliary and fecal excretion. The liver can secrete drugs or metabolites into bile, which then enter the intestines and are excreted in feces. Some drugs undergo enterohepatic recycling, where they are reabsorbed from the intestines back into the bloodstream. This prolongs the drug's half-life. An example of such drug is oral contraceptives. Other routes of excretion includes 1. Lungs. Volatile anesthetics like isoflurane are exhaled. 2. Sweat and saliva. This is a minor route but can contribute to drug testing. 3. Breast milk. Lipid-soluble drugs can pass into breast milk, which is important in breastfeeding mothers. Key pharmacokinetic parameters. Clearance, cl. The volume of plasma cleared of a drug per unit time. It reflects the combined ability of the liver and kidneys to eliminate drugs. Half-life, t-half. The time it takes for plasma drug concentration to decrease by 50%. This determines dosing frequency and how long it takes a drug to reach steady state. Clinically, impaired kidney or liver function can reduce drug clearance, leading to accumulation and toxicity. That's why drug dosing must often be adjusted in patients with renal or hepatic disease. Before we wrap up, let's do a quick quiz to test your understanding of pharmacokinetics. Pause the video if you need time to think. Question 1. Most drugs cross biological membranes during absorption by which mechanism? A. Active transport. B. Passive diffusion. C. Endocytosis. D. Facilitated diffusion. Question 2. Which of the following barriers is the most selective and restricts many drugs from entering? A. Placental barrier. B. Blood-brain barrier. C. Alveolar membrane. D. Skin barrier. Question 3. If a drug has a very high volume of distribution, VD, what does that imply? A. It stays mainly in the bloodstream. B. It accumulates extensively in tissues. C. It cannot cross membranes. D. It is rapidly excreted unchanged. Drop your answers in the comment. In upcoming videos we'll go deeper into each topic with examples, simple analogies, and case studies. Remember to hit that like button, share with your classmates, and subscribe for more student-friendly medical content. Thanks for watching, and I'll see you in the next video.